case discussion series of College of Chemical Pathologists. Today, case discussion is presented by from the National Hospital, Colombo, Dr. Siddhika Usal and Dr. Janisha Gunawardana and Dr. T.M. Taufik will be presenting the cases, and Dr. Gaya Katulanda will be joining today, but due to unavoidable circumstances, Dr. Gaya Nidisanayaka will join with the case discussion. So I invite start the presentation. I think Dr. Siddhika. Thank you.
Thank you, madam. Good afternoon, everyone. Today we are going to present on multifarious Cushing lesson. Our first case is a 22-year-old previously healthy male who presented with weight gain, facial puffiness, and mood changes. He didn't have headache or visual impairment. He denied any intake of steroid. His positive examination findings were high blood pressure with 160/90 millimeter mercury, white purple striae on soft non-tender abdomen, and bilateral supraclavicular and interscapular fat pad. His baseline investigations revealed poor glycemic control with fasting blood sugar of 135 milligram per deciliter, hypokalemic metabolic alkalosis. His thyroid function was within range. So we were suspected on the line of Cushing syndrome for this patient. The initial assessment for hypercortisolism showed overnight dexamethasone suppression test was not suppressed with a cortisol level of 785 nanomole per liter. Midnight serum cortisol was high with 861.72 nanomole per liter. The sample was taken when the patient was awake. To find the cause for Cushing syndrome, we analyzed his ACTH level, which showed 83 picogram per milliliter. As it is high, we did high-dose dexamethasone suppression test to find the source of ACTH, which is suppressed and indicated of Cushing disease. So this chemical analysis followed by imaging. The MRI brain showed pituitary microadenoma with a tumor size less than 6 millimeter. As we are not sure whether the tumor is secretory or non-secretory, we did inferior petrocell sinus sampling in which both side cannulation was successful, and we had central to peripheral gradient of ACTH concentration, and it's concluded as the patient is having pituitary Cushing. So the patient was started on routine oral hyperglycemic agents and antihypertensive for symptom control. Oral fluconazole was initiated, and then he underwent transsphenoidal resection. So when we see the spectrum of hypercortisolism condition in which the patient gets clinical features because of the high concentration of cortisol in the body, it can be divided as ACTH dependent, ACTH independent, and non-neoplastic hypercortisolism. The commonest causes for ACTH dependent Cushing syndrome are Cushing disease, ectopic ACTH, and CRH secreting tumor. Causes for ACTH independent Cushing syndrome were mainly adrenal in origin, which could be a hyperplasia, adenoma, carcinoma, PPNAD, McCune-Albright syndrome, or ACTH independent macronodular adrenal nodules. The non-neoplastic endogenous hypercortisolism causes are morbid obesity, depression, alcohol dependency, and pregnancy, which need to be excluded before further investigating the patient. Usually, a Cushing patient presents with mood disorders, hirsutism, central obesity, proximal myopathy, glucose intolerance, hypertension, immune suppression that leads to recurrent infection, fat redistribution, and osteopenia. Female can present with amenorrhea and decreased libido. Children can present with decreased linear growth also. So when we are clinically suspecting a patient with Cushing syndrome, initially we have to exclude the exogenous intake of glucocorticoids, steroids, in the form of either oral, injection, inhalation, or topical. When it is confirmed, then the baseline investigations were late night salivary cortisol, 24 hours urine-free cortisol, and overnight dexamethasone suppression test. If these tests were normal, then we can conclude as Cushing syndrome is unlikely. But in a patient who is having high clinical suspicion of Cushing disease, then there is a possibility of cyclical Cushing syndrome, which need to be analyzed periodically. If the results are abnormal, then we have to repeat 1 or 2 screening tests. And on top of that, we have to perform dexamethasone CRH stimulation test, desmopressin suppression test, and midnight serum cortisol level to exclude the non-neoplastic hypercortisolism. If these results are abnormal, then we can conclude as that the patient is having Cushing syndrome. Once the Cushing syndrome is diagnosed, we have to do ACTH levels. If the ACTH levels are low, we can say the patient is having ACTH independent Cushing syndrome, and we have to do adrenal imaging to find the source of disease. If the ACTH levels are normal or high, then the next line of investigation is pituitary MRI. In the MRI, if we find a tumor size more than 10 millimeter, then without further evaluation, we can straightly go for the surgery. But if it is less than 10 millimeter, there is a role for inferior petrous sinus sampling. And in that, if the pituitary gradient is absent, we can say that the patient is having ectopic Cushing syndrome. If the pituitary gradient is present, we can say that the patient is having Cushing disease. So once we diagnose the pituitary Cushing disease, the management options are transsphenoidal pituitary adenectomy, that is the first line of treatment. If the patient is not a suitable candidate for surgery, then we can go for medical treatments also. If the patient is having recurrence, especially after 2 repeated surgeries, then there is an option for radiotherapy. Now, for further discussion, I would like to hand over this to Dr. Diane.
Thank you, Siddhika. In this patient presented with Cushingnoid features, as she explained, like moon phase and poor glycemic control, hypokalemic metabolic acidosis. And we have done ODST, which was not suppressed. Midnight serum cortisol was performed and it was high. ACTH level was high and high dose dexamethasone suppression test was suppressed. Imaging showed pituitary microadenoma. Actually, this is a simple case of Cushing disease, a straightforward case. IPSS was performed and central to peripheral pituitary gradient was more than 2 and diagnosed as Cushing disease. I would like to tell you a few important points. In clinically suspected hypercortisolism, screening tests are ODST, 24 urinary cortisol and late night salivary cortisol. If the 2 tests out of these 3 is positive, we can diagnose as patient is having Cushing syndrome. But in our setup, we usually we do not use the 24 urinary cortisol and late night salivary cortisol. We can use low-dose dexamethasone suppression test also as a screening test. To exclude non-neoplastic hypercortisolism, we can use midnight serum cortisol, CRH stimulation test, and vasopressin stimulation test. In ACTH-dependent Cushing syndrome, when a lesion found in MRI, if the size of the lesion is less than 6, IPSS is indicated. And if the size of the lesion is more than 10, IPSS is not indicated. And if the size is in between 6 and 10, as according to some guidelines, this is recommended to go with IPSS. Now, for the second case, I would like to invite Dr. Janisha.
Thank you, Dr. Gayani. Good afternoon. Our second case is based on a 60-year-old woman presented with generalized body weakness and proximal muscle weakness for a duration of 1 month. She also complained of having dark pigmentation, mainly involving her knuckles and nails. She was a diagnosed patient with diabetes mellitus and hypertension for 10 years. She had undergone complete resection of a thymic tumor followed by chemoradiotherapy about 11 years back, and the histology had revealed a well-differentiated thymic endocrine tumor, an atypical carcinoid. However, she had defaulted follow-up after treatment. In the drug history, the patient was on 2 antihypertensives for the control of hypertension and metformin for diabetes control. In the clinical examination, she was afebrile, not pale, but thin-built, and she had no cushingoid features, including moon faces, dorsal fat pad, or purple stripe. However, there was significant hyperpigmentation involving knuckles and palmar creases. Her blood pressure was 150/90, but the rest of the cardiovascular and respiratory systems were unremarkable. In the investigations, she had a hypokalemia with a potassium level of 2.2 millimoles per liter, and her random plasma glucose was 220 milligram per deciliter, indicating poor control. And screening for Cushing syndrome, she had a 9-AM cortisol level of 1,489 nanomoles per liter, which was very significant in the absence of exogenous steroid use. And she had an overnight dexamethasone suppression test of 844 nanomoles per liter, which was unsuppressed. Her plasma ACTH assay was also increased with 146.8 picogram per ml, indicating an ACTH-dependent Cushing syndrome. Cortisol day curve demonstrated a very high cortisol burden with loss of diurnal variation. CECT chest, abdomen, and pelvis revealed a recurrence of thymic neoplasm with extension to para-pretracheal levels and left supraclavicular region. In addition, there was left brachiocephalic compression with collateral drainage. Ultrasound-guided biopsy of the tumor revealed a thymic atypical carcinoid tumor, the same histological diagnosis as the previous tumor. Following clinical examination, history, and investigations including imaging, these were the problems identified. She had a symptomatic hypokalemia, which was refractory, requiring very high doses of parenteral and oral KCl together with spironolactone. She had a worsening glycemic control. In addition, with the ectopic Cushing syndrome, she had a high cortisol burden with more than 1,000 nanomoles per liter of cortisol. Therefore, the overall diagnosis of severe ectopic Cushing syndrome was made. A multidisciplinary meeting was conducted with the participation of specialists in the fields of endocrinology, surgery, oncology, radiology, and chemical pathology. An urgent bilateral adrenalectomy was suggested. The decision to perform bilateral adrenalectomy instead of excision of the recurrent tumor was based on several reasons. High morbidity and mortality of severe Cushing syndrome, inability of complete resection of the tumor, as this was a tumor recurrence with local extension, and also they considered the extremely high cortisol burden and its effects during postoperative period. So in this patient, bilateral adrenalectomy was performed after reducing the cortisol burden with IV etomidate infusion together with 6-hourly cortisol monitoring coordinating with us, the NHSL RIA laboratory. Unfortunately, due to a postoperative lower respiratory tract infection, our patient passed away after 3 weeks of surgery. Regarding ectopic Cushing syndrome, it is caused by secretion of ACTH or CRH from a source outside the pituitary and adrenals. It is rare and accounts for only about 5 to 20% of Cushing syndrome, 10% of ACTH-dependent Cushing syndrome. These are the sources of ectopic Cushing syndrome, and in our patient, it was a well-differentiated thymic carcinoma. Ectopic Cushing syndrome is known to cause acute severe hypercortisolism leading to metabolic derangements. And it's important to identify that typical Cushingite features may be absent in these patients. Identifying the culprit of ectopic secretion may be challenging, and failure to do so may result in poor prognosis. A few words about severe Cushing syndrome. It is diagnosed when there's a massively elevated random serum cortisol of more than 1,130 nanomoles per liter, or if the 24-hour urinary cortisol is more than 4-fold of upper limit of normal, and or severe hypokalemia with one or more of the following features. I have highlighted the features in our patient as our patient fits well into the diagnosis of severe Cushing syndrome. It has a very high morbidity and mortality, and prompt correction of metabolic derangements and medical and surgical measures to lower cortisol levels with vigorous treatment of infections are needed for a better outcome of patients. Now I would like to invite Dr. Gaya for further discussion.
Thank you, Janisha. Unlike in this case, patient presented with features of severe Cushing syndrome. Unlike in previous case, here the patient had generalized weakness, hyperpigmentation, diabetes, and hypertension, and no typical Cushingite appearance was found. And patient's potassium level was markedly low. It was 2.2. Like patient is having a history of thymic atypical carcinoid tumor, which was not followed up properly. And 9-name cortisol was very high. ODST is unsuppressed and ACTH was also very high. Cortisol day curve show loss of diurnal variation, and therefore severe ectopic Cushing syndrome was diagnosed. In this type of case, it is very important to diagnose the source of the ectopic cortisol secretion for the management. A few things to remember. Severe Cushing syndrome is a medical emergency. Ectopic Cushing syndrome can bring about severe hypocortisolism with biochemical derangements, although Cushingite features may be absent. And there's increased risk of infection may persist even after immediate cortisol reduction. Due to high recurrence rate, proper patient education and follow-up of paramount importance in ectopic Cushing syndrome. This is the end of second case. Now I would like to invite Dr. Srinath for the third case.
Thank you. Good afternoon, everyone. I'm going to take you all through my third case. This is about a 33-year-old woman who was recently diagnosed with diabetes mellitus and hypertension. She has noticed recent weight gain. She has gained 6 kilograms over 2 months. She gave a history of hirsutism and oligomenorrhea. She had a round face with facial plethora. Dorsal-cervical and supraclavicular fat distribution was seen. No history of easy bruising or proximal muscle weakness. She was diagnosed to have depression, and it was complicated by suicidal ideation. She had persistent low mood despite antidepressants. Her systemic examination was unremarkable. She did not give any family history of endocrine or psychiatric disorders. Biochemical investigations. She had poor glycemic control. Her serum potassium and arterial blood gas analysis was normal. Overnight dexamethasone suppression test, low-dose dexamethasone suppression test, and high-dose dexamethasone suppression tests were not suppressed. To see the cortisol burden, the cortisol day curve was planned. Her cortisol concentration was fluctuating around 500 nanomole per liter throughout the day. The midnight cortisol level way above the cutoff for midnight cortisol concentration. To distinguish between ACTH dependent from ACTH independent, we had to do plasma ACTH level. The plasma ACTH level came as undetectable. We did all other pituitary hormones and adrenal hormones, all were in normal limits. CACT abdomen with adrenal protocol was planned and it had bilateral lesions. So with all the positive findings, the differential diagnoses were bilateral adenoma, primary pigmented nodular adrenal disease, primary bilateral macronodular adrenocortical hyperplasia. To find out the functioning lesion, adrenal venous sampling was done. Usually, adrenal venous sampling is planned for primary hyperaldosteronism. But here, we have done it in a case of ACTH-independent Cushing syndrome. We have used aldosterone as the reference hormone to calculate the selectivity and lateralization indexes. According to the selectivity index, left adrenal vein was successfully cannulated, but we could not take samples from the right adrenal vein, as there was an anatomical variation. Therefore, we took samples from common trunk, but unfortunately, its cannulation also wasn't successful. But in the left adrenal vein, cortisol concentration was 5 times higher than the periphery. So these were my references to select a reference hormone for the AVS in an ACTH-independent hypercortisolism. Apart from aldosterone, plasma catecholamine, metanephrines, and dihydroxyepiandrosterone sulfates were used as reference hormones. Stress-induced fluctuations in aldosterone secretion and the shorter half-life than cortisol may interfere the interpretation of venous sampling. Furthermore, aldosterone and cortisol co-producing adenomas can make interpretation difficult. When we use catecholamine, interpretation of AVS is questionable due to its large inter-individual variations. At the same time, it is derived from adrenal medulla, and it's not necessarily represent the venous drainage of adrenal cortex. Dihydroxyepiandrosterone sulfate as a reference hormone is probably not suitable due to its long half-life. But plasma metanephrine was suggested to be a promising reference hormone due to its short half-life, and it is not consistent with the stress. So for this patient, adrenalectomy was planned. According to the AVS, the left adrenal had the lesion. Therefore, they attempted the left adrenal gland and they took a fresh frozen biopsy, and it was consistent with primary pigmental nodular adrenocortical disease. Therefore, ultimately, they did the bilateral adrenalectomy for this patient. So you can appreciate in the characteristic histological appearance, the bead on string appearance in the cross section of the both adrenals. Patient recovered uneventfully post-operatively, and she was discharged with oral hydrocortisone and other clinic drugs. Few words about primary pigmental nodular adrenocortical disease. It is a rare manifestation of ACTH-independent Cushing syndrome. More than 90% of reported PPNAD associated with Carney's complex. The Carney's complex consists of hypopigmented skin lesion, atrial myxomas, and other tumors of endocrine glands. The disease usually presents in second decade, and it has a female predominance. The hypercortisolism is resistant to dexamethasone and it has a serum ACTH levels of low or undetectable. The treatment of choice is bilateral adrenalectomy due to recurrence when unilateral or subtotal adrenalectomy was done. But PPNAD does not increase the risk of malignancy. The gross and histological appearance of PPNAD is characteristic and genetic studies are not necessary for the diagnosis. Detailed investigation and careful follow-up such as echocardiogram and thyroid ultrasounds at regular intervals indicated to detect other manifestations of Carney's complex. Even though the genetic studies are not necessary, the PPNAD associated with the Carney's complex, they had PRKA-R1A mutation. In isolated PPNAD also, they had the same mutation as well as phosphodiesterase 11A4 mutation. That's all for the case study. Now I will hand over to Dr. Gaya Disanayaka for the further discussion.
Thank you, Srinath. This patient presented with typical features of Cushing syndrome, such as round face and patient had hypertension, diabetes, and depression also. ODST, low dose dexamethasone suppression test, and high dose dexamethasone suppression test was unsuppressed. And cortisol day curve, loss of diurnal variation. And midnight serum cortisol was high and ACTH was suppressed. In CECT, abdomen bilateral adrenal lesions were found, and the diagnosis was diagnosed as primary pigmented nodular adrenal disease based on histological findings. This is a very rare case, and at NHSL, I think this is the first case we found in diagnosis. And usually we do AVS for primary hyperaldosteronism, but in this case, we have done AVS also. Unfortunately, it was not successful. And in AVS, usually we use cortisol to calculate selectivity index, but in this type of case, we have used aldosterone to calculate selectivity index. As this is a rare case, I would like you to tell a few important points we found in research articles. In the AVS, with a selectivity index less than 2, but still we can calculate, we can diagnose successful cannulation based on cortisol level. If cortisol level in adrenal veins to peripheral vein more than 10 times, we can say that cannulation is successful. And also, if the adrenal vein to peripheral vein cortisol gradient of more than 4.1 or greater bilaterally was consistent with bilateral autonomous cortisol secretion. Cortisol gradient in adrenal vein to peripheral veins more than 6.5 was consistent with cortisol secreting adenoma. In this case, our cortisol gradient in adrenal to peripheral vein was 5.5. So the cortisol secreting adenoma was excluded by it. And then we could diagnose this from the histology report as primary pigmented nodular adrenal disease. Thank you very much for the listening. If you have questions, you can ask now.
Thank you very much, team from the National Hospital Colombo. And it's very interesting cases were discussed regarding and very rare cases related to the Cushing. And the forum is open for questions now. In the absence of questions, I invite Dr. Madhuri, Secretary, College of Chemical Pathologists, to deliver the vote of thanks.
Thank you, Dr. Dulani. So now we have come to the end of the case discussion. It is my pleasant duty to thank those who contributed to make this case discussion a success. Firstly, I would like to thank Dr. Gaya Katulanda, Consultant Chemical Pathologist at National Hospital, for all the support and guidance given to the trainees in preparing the case discussion presentation. Also, I would like to thank Dr. Gayani Disanayaka, Acting Consultant, District General Hospital, Gampaha, for conducting a very interesting case discussion. I would also like to thank Senior Registrar Dr. Zeenat and the two registrars, Dr. Siddhika and Dr. Janisha Liana Gunavardhana, for their excellent presentations. Also, I would like to thank our participants joining with us from all over the country. So without your presence, this wouldn't have been a success. Hope to see you all again in 1 month's time in a session like this. Thank you.
Thank you very much for the participation. We will end the session now. Thank you.